I had a request. We're gonna do diabetes. So one thing you'll learn about nursing is that we learn about diabetes forever and ever and ever. It's never ending. There was one time I had graduated and probably 3 years into nursing, and they were still teaching us at every new facility how they do their diabetes management and diabetes education, and I would just sit there because I was so tired of learning about diabetes. But it's an important subject. A lot of Americans, a lot of our patients have diabetes, whether that's why they're in the hospital or not. So it's very important to understand the mechanisms within the body, what causes diabetes, what makes it worse, and then also conditions associated with diabetes. So we're going to get started. It's a lot of fun. There's different types of diabetes. There's diabetes mellitus and diabetes insipidus. We are going to talk about diabetes mellitus. We'll talk about insipidus another time, maybe during a trauma live study session or something like that. But we're going to talk about diabetes mellitus. So we're going to discuss the kinds of diabetes that's out there. Diabetic ketoacidosis, that's one of the complications of diabetes. Hyperosmolar hyperglycemic syndrome, also known as HHNK. We'll get into that a little bit. A lot of diabetes conditions have several different names. It's just kind of over the years things have changed, just like in healthcare. So they try to make names a little more suited to what the disease process is. So we'll go over all the different names because you might hear them when you're in the workplace. You might hear all the different names, and that way you'll know this is what that means. This one, Euglycemic diabetic ketoacidosis. This was a new one on me this past year, and I actually at NTI went to a class or course. At NTI they have different sessions, and one session was on euglycemic diabetic ketoacidosis. So that's a very interesting condition, and we're going to go over that. Okay. I don't know how many of you remember this, but there was a guy named Wilfred Brimley, and he used to do diabetic commercials for Liberty Medical. He would have like an opening scene, and then he would talk about diabetes and that you can get your medical supplies for diabetes through Liberty Medical. So whenever I think about diabetes, I think of him, and then I also think of this meme that had this cat that really looked like him. And that's kind of what stuck in my head the whole time. If you don't know about Wilfred Brimley, he was a TV star. The one that I remember him in, and it's just because my grandparents watched it, was The Waltons. But he was a huge advocate for diabetes once he was diagnosed with it. He was a big advocate for diabetic education. He was a big participant in the American Diabetic Association. So he really worked as hard as he could with diabetic groups to help improve conditions for people who have diabetes. So look him up. It's very interesting what he did for the American Diabetic Association and diabetics. But this, like I said, every time I think about diabetes, that's what I think about. All right, let's talk normal pancreas stuff. Okay, normally you eat something, and during the digestion process, that blood sugar that's being broken down in your food, your glucose, hits the pancreas. And the pancreas is like, whoa, we got to take care of this. So they end up, this is where I wish I had my pointer. Oh, you do see this, okay. You got to follow my little mouse here. So then the pancreas ends up releasing insulin. What that does is it goes onto the tissue cells, helps glucose go into the tissues. You don't want to see that. And then it also helps store extra glucose into glycogen. Now, I distracted myself with that. Now, let's say that you are in the middle of class and you didn't eat breakfast, or you're in the middle of your shift. This is a good example. You're starting your shift off and you didn't eat breakfast and hit the floor running, and all your patients need something right away. So you have low blood sugar. So what do you need? This little picture down here is low blood sugar. What do you need? You need sugar, right? So that hits the pancreas, and the pancreas is like, whoa, we need to get something going now because she's going to collapse if we don't fix this. So it produces glucagon, which then goes to the liver, then causes the glycogen to convert back into glucose, which raises your blood sugar. So this is how it normally goes. And if you see here, how does insulin work? Well, insulin is the ticket for glucose to get into the cells. So the glucose just wants to get into the cell and party. That's how the cells function. So glucose wants to go to this party, and the cell wall, the bouncer, says, do you have a ticket? I need to see your ticket. And glucose says, oh yeah, and shows his insulin. So insulin gets brought to the bouncer and the glucose gets to go in. Another way to look at this is the key for glucose to get into the cell. I like the party one just because it's more interesting. So glucose can't get into the party, can't get past that bouncer without insulin as its ticket. And this is how everything is normally supposed to work. So what happens with diabetes? Let's look at types. Now that we know how things normally work, we're going to throw wrenches into the normal way things go. We have type 1 diabetics. Now, this has a couple different names. Type 1 diabetes, juvenile onset diabetes, that's an older name, insulin dependent diabetes, and autoimmune beta cell apoptosis, BCA. What do all these names mean? Well, type 1 diabetes is a condition where the person's body attacks the beta cells that produce the insulin, and then they don't produce insulin. So their body attacks the beta cells and there's no more insulin. No more insulin. So their body cannot whatsoever produce insulin, which causes the cells not to be able to utilize glucose. Because remember, glucose, who wants to party, they need to have that ticket of insulin. A lot of times you see this in children, and that's why they named it juvenile onset. And then they also named it insulin dependent because these people cannot survive without insulin. They have no insulin in their body. They need insulin. And then autoimmune beta cell apoptosis. The reason why they have this name is because it describes type 1 diabetes. It's not like type 2, which we'll get to. It's the reason why this person has diabetes, type 1 diabetes, is because their body is attacking the beta cells. So you might hear all these different names. They all mean the same thing. It means people who are unable to make their own insulin. Type 2. This is the one that you hear a lot about because it's a condition that we can manage a little bit better. So type 2 diabetics can also be known as adult onset, can also be known as insulin resistant diabetes. I forgot my little parenthesis here, so pretend there's one there. Wouldn't work in Excel, you need to close the parentheses. That's a nerd joke. Okay, maybe it's not even a joke. A lot of times you'll see type 2 diabetes occur more in adults over 40. However, you may start seeing it younger. But in the most part, if you work in the adult population, you'll see more of type 2 diabetes than type 1s. You will have type 1 diabetics, but in my career, my experience, I've mostly seen and taken care of type 2 diabetics. And again, just like the autoimmune beta cell apoptosis here, insulin resistant diabetics, or what insulin resistance means is that they still produce insulin, but the cells are so tired of seeing all that insulin to process the glucose that they start to not respond as well to the insulin. Gestational diabetes. This is pretty easy. This is diabetes that occurs during pregnancy. Sometimes that could be resolved after pregnancy. Sometimes that's a precursor to type 2 diabetes. However, gestational diabetes occurs during pregnancy. That's why if you hear or you ever talk to someone who's pregnant, you will hear that they have to do that sugar test, that glucose test where they drink that nasty syrupy stuff. I've done that test because my doctor thought I was diabetic, and I wasn't diabetic, but I tried to argue that, but I had to sit there. It was about a 3-hour test because they take your glucose level lab, then you drink that sugary stuff, and then you have to take another blood test soon after that in a time frame so they can see if your body clears a certain amount of that sugary drink. And it's disgusting. It's really gross. Really wish they have a lot of sugary drinks out there in the world. Really wish they had let us drink something a little bit tastier than that. It was almost like drinking Tums crushed up, super sugary Tums crushed up in water. Okay, so if you like pictures, I have a couple pictures. This is a chart kind of showing you the difference between type 1 and type 2 diabetes. As you can see here, type 1, little to no insulin. These people usually make no insulin. Type 2, you make insulin, but your body's like, I'm tired of this insulin. You gotta do better. Here's the different names. Here's the percentage of people that have it. And then you can kind of see here, the ages, it's 40 to 45, but we are seeing it younger for sure. Here the symptoms are we're going to go over symptoms, but the symptoms of uncontrolled diabetes, or when this is not type 1 or type 2 not being managed, are these symptoms. And type 2 has a little bit more involved with it. It slows down wound healing. So you sometimes will see these diabetics, they have sores that take forever to heal. So these are the main differences between these two types. And then this is another picture for you guys. So here you can see type 1 diabetes. They've got all this glucose, but they don't got tickets to the party. They don't have tickets to the party. So all this glucose floating in the bloodstream, but they can't get into the cell. The bouncers won't let them in. So the cells cannot absorb glucose. Here, there is insulin, but the bouncers are now saying, hey, you're going to have to give us a cover charge too. So the bouncers on the cells are saying, we're going to need more than just your ticket. So the glucose isn't allowed in because they need more than just their insulin tickets. They need more insulin. They need a cover charge in order to get to this party in the cell. All right, now we're going to start talking about some of the conditions when things go wrong. So diabetic ketoacidosis. This is life-threatening. It can happen very quickly, and so you need to treat it. Remember, if you were with me with my first stream on acid-base balances, our bodies do not like an acidotic environment. Cells don't function well. Our bodies just don't function well. So if you have someone who's in diabetic ketoacidosis, it's super important that you get treatment for them right away. So how can you recognize this? Well, they're going to have blurred vision. They're going to be peeing a lot. They're going to, like, a lot. And we're going to talk about why all these things occur. They're going to be very thirsty. They're going to smell fruity. That's the ketones that you're smelling, which is in the ketoacidosis, which causes the ketoacidosis. You're going to, their urine is going to smell fruity. They're going to feel sick. They might have some stomach pain. And then, of course, they can be confused. And then if it gets really bad and it goes on for a while, they can become unresponsive and pass out. Glucose levels for this type of patient is going to be 200 to 800. I've seen higher than 800. I actually had a patient a couple weeks ago where she came in with 1,000 something glucose, but she was in diabetic ketoacidosis. She must have just, her body was used to a higher sugar, and so when your body is used to a higher sugar, it can tolerate higher numbers before going into ketoacidosis. A lot of times, if you have a patient who lives routinely in a 200 range and you start trying to lower their blood sugar, they can start getting symptoms of hypoglycemic or hypoglycemia because their body's so used to having that sugar in their body. All right, and then your urine is going to be positive for ketones. What is another thing? Your serum potassium is going to be high. Now, you think if you're peeing a lot, you're going to be pushing potassium out, but that's not the case. Your body may have normal to low potassium, but in your bloodstream, because you've been peeing so much, you're dehydrated. So your serum potassium is going to be high. And what is potassium related to? The heart. So when your potassium is high, you can have issues with cardiac arrhythmias. You'll see on the EKG you have very peaked T waves. And if we ever talk about cardiac rhythms, which we will because that's another fun thing to talk about, we'll look at an EKG with high potassium. But it's very distinct when you run an EKG strip, or if you have your patient hooked up to a monitor. You'll have the QRS and then you'll have the T wave, and it'll be like really, like it almost looks like its own QRS sometimes. Okay. Then I think if it carried over, yes. So if you know Mary Poppins, old school, I thought this was funny, so I put it on there. All right. So here, remember, this is the normal functioning. So what happens in diabetic ketoacidosis that is different than this? Well, so this person is eating food, so they have high blood sugar, and that is going to go to the pancreas, and the pancreas is going to produce insulin. However, the tissue cells are saying, no way. So the high blood sugar keeps getting circulated. But because of that, the cells are not getting energy. So what happens when you are no longer getting energy from glucose? Your body starts to break down muscle cells and fat cells to be able to provide energy for these cells. The cells start to go into a keto metabolism. So this all goes into the liver, as you can see here, and the liver goes ahead and converts those amino acids, the fatty acids, the glycerol. It converts that to glucose and pours that in the blood system because it's saying, hey, this person isn't getting glucose. It doesn't know that there's glucose in the bloodstream already because you're eating food. It's being told by the cells, hey, we don't have enough glucose in here. You need to do something. So it starts doing its glyconeogenesis, which we'll talk about in a little bit, which is pretty much the process of converting, it's on this slide, sorry, converting glycogen into glucose. And then the liver also starts converting the fatty acids into ketones. So that all gets dumped into your bloodstream, which then increases your ketones and your glucose in your bloodstream. Why do you have ketones in your urine? Well, you're going to have ketones in your urine because you've got so much glucose in your body that your kidneys, it increases the osmolarity of your bloodstream, right? Your bloodstream has a certain balance of osmolarity. If you're dehydrated, that goes up. If you've got too much water, that will go down, and it's based off of the components of the blood and electrolytes in the blood. Well, when it's got all this extra stuff in it, like ketones and glucose, your kidneys are trying to get rid of it. It's filtering out that blood, it's getting rid of all that. So that's how you end up having ketones in your urine. Treatment. So, these people are dehydrated. Remember, they are peeing. They are peeing up a storm. So you need to replenish those fluids. They're going to be very dehydrated. A lot of times we'll start with normal saline. We'll give them 1 liter or 2, sometimes more. Then over the course of treatment, you're going to change that to 0.45. That is half normal saline. Because you don't want to drive their sodium up. We're going to have more issues. If you remember from our increased ICP, we're going to have more issues if we get our sodium too high. Next, we're going to then switch to D5 and whatever else. Sometimes it's NS. It usually isn't just plain old D5, but sometimes it could be D5.45. It just kind of depends on your facility. And we start that once the patient gets to around 250 of their glucose number. Why do we do that? Well, if you get a patient in that has a blood sugar of 800 and we're giving them insulin to bring that down to try and correct all of this issues they're having, you get to 250 from 800, your body is going to need sugar to prevent it from dropping like that. If you drop like that, we're going to swing the whole other way, and that's not good either. And there have been patients that I've had where they're super sensitive to constant insulin that they drop, and you have to catch them before they drop and they become hypoglycemic. Insulin. Usually these patients are going to go to the ICU, and when they're there, they're going to get an insulin drip. And then with that insulin drip, they're going to get glucose checks. So every hour we check their glucose, and then facilities usually have a built-in formula. I haven't been to a facility yet that makes you calculate it out, but usually, for example, at my facility, you type in what the glucose level is for the patient. The computer does a formula and spits out you need to be at this many units. So then you go over your pump and you set this many units, and then if you set your pump right, it'll alarm the next hour for you to check and reset. So every hour you're checking that glucose, and you're readjusting the insulin. We're going to slowly bring this person down. And that formula usually has the safeguards in that if you go from 800 to 500, they're going to say, oh, we need to slow down this drip because we're going too fast. It's really handy. I'm very happy they have that, because can you imagine every hour trying to figure out a formula and figure out what your drip rate should be at? It'd be super time consuming, and we don't have time for that. Especially when we have technology that we can just plug in numbers and have a result, because a computer can do all the computing for us. These patients are normally NPO, and if they are unconscious, you're going to get an NG, and you're going to stick that in their nose. And maybe they won't be unconscious then. But Why do we do this? Well, we don't want them to throw up, of course, but we also need to be very strict about their electrolytes and the positive and negative ions in their bloodstream. So it's very important that these people remain NPO while their body is still in that acidotic state. Remember, bodies do not like acidotic states. Cells do not function well in an acidotic state. So we have to correct that before we put even more stressors on the body. All right, electrolytes. Along with glucose and ketones, you're going to be getting rid of electrolytes. So it's very important to watch those. This is also how you're going to calculate your anion gap. Your anion gap is, what will tell you when we're out of an acidotic state. Although if you're in an ICU and you have the ability to do so, ABGs are really good at that too. Sometimes doctors will ask you to do a VBG, a venous blood gas, and they can calculate the state of the body based off of that VBG. But an ABG is going to tell you very well whether you're in an acidotic state or not. An ABG is an arterial blood gas. A lot of times they can get it from the radial artery there. And then in a little bit we'll talk about anion gaps and how to calculate that. So this beta hydroxybutyrate, I practiced that word today. This is ketones within the serum. So you have ketones in the urine. However, this is the lab test that you can test for ketones within the blood. This is another one that was kind of new on me within this last year, and luckily I'm with a lot of doctors that can explain these things to me. But that is what we use when we have a diabetic. We'll draw electrolytes, and then we'll also draw a beta hydroxybutyrate. Anion gap. So if you Google this, if you learn in school, there's two different ways that we can calculate this. You can do the simpler way, where it's just which is just sodium chloride and bicarb, or you can do all of the positive ions and all of the negative ions. But what the anion gap is showing is how far apart are those ions. The bigger the gap between those ions, the more acidotic the patient is. So, you don't have to memorize that. It's going to be on the next page. So we want to mind the gap. Whenever we have a DKA patient, we want to mind the gap. And when you take these electrolytes and the beta hydroxybutyrate, you're going to take that about every 6 hours, sometimes every 4 hours if they're really bad off. And what you will find is that when the patient first comes in, that gap is really big. It's called open. You have an open gap. And as you correct the insulin, that gap gets smaller and smaller and smaller. If you are in a city area, or if you've never been in a city, this here, mind the gap, is when they have subways or trains, and there's usually like a little gap in between the platform and the train, and people get stuck in that gap. So they had to put signs everywhere saying, don't forget there's a gap there. All right, so let's practice. So here is your electrolytes for this patient. Sodium's 149, potassium's 4.5, chloride is 105, and bicarb is 25. How would we calculate this? We would take the positive ions and the negative ions, and we're going to subtract it. So if you want to do it the longer way, you're going to go 149 plus 4.5, your two positives, minus the two negatives, 105 and 25. Sodium and potassium are going to be positives, and then your chloride and your bicarb are going to be negatives over here. So you add those together, and then you subtract them. What do you get? You get 153.5 minus 130, or if you do it the shorter way, 149 minus 130. And they just take potassium. In the shorter version, they just take potassium out. So we end up with 23.5, or we end up with 19. At any rate, an anion gap normal value should be between 8 and 12. 8 and 12. That's when it's considered closed. A closed anion gap is between 8 and 12. So 23.5 and 19, definitely higher than 12. So this patient's anion gap is still too far apart. I've had patients that are so thirsty and they're hungry and they haven't eaten in a long time. You know, they're starting to feel better because we're correcting things, so now they want to eat, but you have to be the bearer of bad news and the bad guy and say, we can't eat yet. We can't drink water. We can't do anything just yet. Your gap, or the measurement that we're looking at, is still open. The gap is too wide, but I'll get you ice water as soon as we can. Customer service with a smile. All right, that's about all I have for DKA. Remember, if you have a diabetic patient, any type of stressor can throw that patient into a DKA because it's putting more stress on the body and making it want more glucose, making it want or need more. So a lot of times if you have a patient who has a very bad infection, they will go into DKA. Any injuries, any sort of stressors, it could even be surgery. So you want to make sure that you really monitor your diabetic patients, even if they did not come in for diabetes, because even in a hospital setting, if not monitored closely, they can go into a DKA. That's if a lot of times hospitals are going more towards not using patient, at least my facility, we don't use patient medication as much, like metformin or glucophage or the other ones. We strictly use insulin because we're able to control a patient's blood sugar by using a sliding scale and using longer acting insulin, and even if it comes to it, an insulin drip. Some of our very sick patients will be on insulin drips along with everything else. All right, hyperosmolar hyperglycemic syndrome. It's also known as HHNK, hyperosmolar hyperglycemic non-ketotic coma. These patients don't need to be in a coma, so that's why it's always good to call it hyperosmolar hyperglycemic syndrome, HHS. So what is this? Well, this is where the patient's body is producing enough insulin to get the glucose into the cells, but not a whole lot. So the sugar slowly starts to climb. Those bouncers are like, oh, you look good. We can let you into the party. We'll take your insulin ticket. And then the next glucose, they're like, we don't want you here. You're going to have to give us a cover charge. And the glucose is like, I don't have enough money to get into this party. So they get back off into the bloodstream. And over time, that body becomes more and more resistant to insulin. So what you'll find in these patients is that they are severely hyperglycemic. But despite having all that blood or glucose in the blood, they don't go into ketoacidosis because the bouncers are still letting some glucose in with insulin. You have just enough insulin for cells to utilize some glucose, so you either have no ketoacidosis or no ketones in your bloodstream and urine, or maybe just a little bit. And these patients, the glucose is high in thousands. This is going on for a long time. That glucose is building up, so you are going to have high glucose. When I was studying for the CCRN, I was using Laura Gaspargas's study guide, and if you are studying for CCRN, I really do highly recommend hers, as well as Nicole Kupchak's. They're both really great. They really drive points home, and they make it funny so that you can remember it. anyway, Laura was talking about how she brought her kids to a nursing home to visit with the elderly people that lived there, and the staff knew she was a nurse, and one of the residents at that nursing home, came up to her and said, "Hey, can you help me? I need to go use the bathroom. Would you walk with me?" She goes, "Sure, I'll take you there." And she walked into this lady's room, and she stepped on the floor, and it was sticky, just so sticky. She goes, "What's going on? Why is your floor so sticky?" She goes, "Oh, I have to pee so much that she was peeing on herself, peeing all over the floor. Ended up that her sugar was over 1,000, and she was peeing so much because her body was still trying to get rid of that glucose, and it was coming out in her urine." So remember that story and associate with HHNK or HHS. She ended up going to the hospital and getting treated. She didn't end up having that altered mental status. But if you let this go long enough, that patient is going to have an altered mental status, and they could go into a coma. All right. The treatment I want to go back real quick. The treatment for HHS is similar to the DKA. You're going to want to get that sugar down with insulin, so you're going to do hourly checks, and then you're also going to do your lab draws for this as well. You're also going to have to intubate if it gets bad enough where their mental status gets to a point where they can't support their own airway. Okay, sorry, I had a memory. So this is Euglycemic diabetic ketoacidosis, and I only learned of this within the last couple of years, and the doctor, the attending that was admitting the patient, so I work in an ICU, and a lot of times our beds are at premium. You know, we have patients coming in all the time. We need the beds. So this patient was in the ER, the patient with EDK, and I was looking at it said that he had diabetic ketoacidosis. It didn't say euglycemic, it said diabetic ketoacidosis. So here I'm thinking high blood sugar. The patient's blood sugar was normal. I didn't understand. Why are we admitting this patient? Why are we taking this patient in an ICU when their glucose is fine? We don't need to do anything in ICU. However, in talking to the attending, and I was professional about it, I asked him, "Can you explain why we're admitting this patient?" And he said, although this patient's sugar is normal, this patient is in a ketoacidotic state because, and he explained the process, which I'm going to now, because their body is maintaining the blood sugar level. All right, so as I talked about before, glyconeogenesis is where glucose is synthesized from non-carbohydrate metabolites. So that means the liver starts breaking down muscle and fat and the stored glycogen to start making glucose and pouring it out into the blood. So euglycemic diabetic ketoacidosis, or EDK, it's still very weird to say that. It's when a person is already carbohydrate deficient, so they're not taking in a lot of carbs, and then at the same time they're having an insulin resistance or an absence of insulin at the same time. So if you think about it, if you think about maybe a diabetic who goes on a keto diet, this could lead to a euglycemic diabetic ketoacidosis because they're not taking in a lot of carbs and they're already insulin resistant. So what carbs they are taking in is causing the insulin, or causing the glucose to go up, or stay normal, I'm sorry. They balance each other out. So the liver starts to produce glucose by gluconeogenesis, to supplement the carbohydrate deficiency, which then depletes the liver of all of that. So then the liver isn't producing any more glucose. So we're not pouring glucose out. Whatever glucose is in the bloodstream is being put in the bloodstream by eating whatever little carbs this person is eating. So then, like I said, the glycogen stores are low, so then the liver doesn't throw out more glucose, which then causes the glucose to remain normal. Glucose then is also excreted out the kidneys. I took this picture from our NTI, or the NTI course I took on Euglycemic Diabetic Ketoacidosis. I did not draw this. I'm not going to take credit for that at all. But this is the liver and these are kidneys. So any little bit of glucose that might be extra, the kidneys are getting rid of normally. So then that also keeps the glucose normal within the body. So you're not taking in a lot of carbs. Your liver is not making a lot of carbs from glycogen. And then your kidneys are getting rid of extra glucose. So that keeps the glucose normal. However, these patients also have this insulin resistance. So remember, whatever glucose is in the blood is not getting into the cells. So the liver starts that process where it starts breaking down the fat and muscle, causing the ketones to spill into the bloodstream, causing the ketoacidosis. You're getting ketones in your body because your cells are not getting whatever little glucose you do have. To save the cells, fatty acid breakdown, protein breakdown, just like in DKA, EDKA just doesn't have a high glucose. What can cause EDKA? It's so hard to say. Well, the course that I took, the session that I took, she said the 5 I's: infection, infant, infarction, insulin, and indiscriminate diet. I don't know what she meant by indiscriminate diet, except some of the diets that are lower in carbs and starvation diets. So you gotta be careful with some of those diets out there because they aren't always a good fit for everybody, as evidenced by Euglycemic Diabetic Ketoacidosis. So infection. If the body has been stressed for a while and it gets rid of those stores that the liver has of glycogen, then you're going to have no glucose being released from the liver, and your body is already stressed out. So from the infection, which can cause your glucose to just sit normal, but make your body start to go into producing ketones and protein. Infarction, that's another stress. Insulin, that's insulin resistance. Oh, I forgot infant. A lot of pregnant females who are right on the beginning stages of gestational diabetes, this can be something they develop because their body is already trying to produce enough glucose to support the mom and the baby. So your liver uses up those glycogen stores pretty quickly to help support that. So that can cause it. And then insulin is the resistance or absence of insulin. These meds, so this is injection meds for diabetics. And what it does, we'll talk about it on, I believe, on the next slide, but it will cause your glucose to be peed out through the kidneys, and which causes your glucose to remain normal, but your cells are still not getting glucose. So starvation. So at the beginning of keto diet initiation, a lot of patients may come in with this, especially if they're already type 2 diabetic. Pancreatitis. Your pancreas is sick, it's inflamed, it's infected, and it spits out a little bit of insulin, just enough insulin to get rid of some of the glucose, push it into the cells, but not enough to where your body doesn't go into ketoacidosis state. And then drug use can also cause this. So the thing with the, let's see, I have it written down. So the SGLT2, this drug, like I said, this is a medication that is used for type 2 diabetics. It's oftentimes an injectable meds. It's a newer drug, and then it also can be used in cardiac patients, but it can cause euglycemic diabetic ketoacidosis because it gets rid of that glucose through the kidneys, and then it also causes I didn't finish my note here. Gets rid of glucose through the kidneys, causing the glucose to remain normal in the bloodstream, and then as a result, it doesn't help the cells at all to get the glucose. You need insulin for that. That's not insulin. So your liver starts to produce, it starts the process of breaking down muscles and cells, causing ketones to be dumped into the bloodstream, and then also, because it's already getting rid of glucose in the urine, getting rid of some of that ketones in the urine as well. All right, have I confused you guys yet? A lot of information with diabetic, ketoacidosis, diabetes, and all of that good stuff. You ready for some questions? I'm ready for some questions. That's another thing, my Wacom pad is not working today either, and the one mouse I was using, the battery died, so stuck with my laptop mouse. Okay, this is an NCLEX question. A lot of the questions I don't have multiple I don't have pick all that apply. It's pretty simple questions. So this one, the nurse is admitting a patient diagnosed with type 2 diabetes mellitus. The nurse should expect the following symptoms during an assessment. Except let's look at the answers. Hypoglycemia, frequent bruising, ketonuria, or dry mouth. All right, let's read the question again. The nurse is admitting a patient diagnosed with type 2 diabetes mellitus. The nurse should expect all of these except which one? All right, so let's go through this. In a patient with type 2 diabetes, it doesn't say what this patient is being admitted for. However, they're being admitted and they have type 2 diabetes. Would they have hypoglycemia? Would you expect that? Maybe if they took too much insulin, but most likely you wouldn't see hypoglycemia. You might see hyperglycemia or normal glucose, but not necessarily hypoglycemia. Would you see frequent bruising? You might. It depends on how long they've been in type 2 diabetic. Remember, type 2 diabetics have delayed wound healing. Their wounds don't heal very well because the cells aren't metabolizing that glucose well enough to heal. So it also affects their circulation, so that could be a reason. Ketonuria. Do you expect them to have some ketonuria if they're being admitted to the hospital? Maybe, because they're sick, and if they have type 2 diabetes, that may be causing DKA, right? So that might be one. Dry mouth. That could be it too. So which one would you expect? Let's go back to our little man here. All right. So they're going to be very thirsty, people with diabetic ketoacidosis. And we don't know if this guy that we are admitting with type 2 diabetes has diabetic ketoacidosis, but he's being brought into the hospital, which means he's sick from something. So he is being stressed, and then on top of that, Sorry, my screen's messed up. Start over. Okay, so he's stressed out. He's in the hospital. So that's going to be causing his diabetes to go haywire anyway. So he would probably have higher blood sugar. If you think about it, if a patient is coming in stressed out and a diabetic, their blood sugar is probably going to be higher. They're going to have dry mouth because if their blood sugar is higher than normal, they're going to be thirsty. And then, what was the other thing the patient had? Ketouria. So pretty much all those things fit together. I'm trying to fix my screen so I don't see this. There we go. Okay. So they're going to have we're guessing that this patient's going to have dry mouth. They're going to have ketones in their urine, and because they're type 2 diabetic, they probably have some circulation issues, delayed wound healing, so we might see frequent bruising. Another way to approach this question is what all fits together and what doesn't. One of these things is not like the other, so we group it together like that. Well, B, C, and D all have to do with high blood sugar, which our patient probably has because they're stressed out in the hospital. So the answer would be A. We don't really expect this patient to have hypoglycemia. Did you get it? Next one. This is another NCLEX question. A clinical feature that distinguishes a hypoglycemic reaction from a ketoacidosis reaction is blurred vision, diaphoresis, nausea, weakness. All right. So, a clinical feature that distinguishes a hypoglycemic reaction from a ketoacidosis reaction is, can you have blurred vision if you have hypoglycemia? We've all been hypoglycemia at one point in our lives. We all have. Do you remember what that feels like? It feels like you're going to pass out, right? You start to get that cold, clammy sweat. You start to get maybe a little nauseous, get lightheaded. You have that feeling like, man, I need to eat something. Your sugar is starting to drop. Do you have blurred vision with that? Maybe, but you also have blurred vision with ketoacidosis, right? Remember that man? He has blurred vision. Diaphoresis, do you get that with ketoacidosis? Not normally. Remember, in ketoacidosis, you're dry, you're dehydrated. One of the first things we do to you when you come in is we give you a crap ton of fluids. So most likely he's not sweating. Nausea, that can occur with both, right? If you're about to faint, you got that nauseous feeling in your stomach. And in ketoacidosis, you're in that acidotic state. You're also feeling pretty gross, nauseous. Weakness. You also can be weak in ketoacidosis and hypoglycemia. Ketoacidosis, your cells are not getting that glucose, that energy it needs. And in hypoglycemia, you're also not getting glucose because your blood sugar is low. So, again, one of these things is not like the other. Can you tell me which one it is, or can you figure out which one it is? If you said B, you are correct. I rarely see a patient come in sweaty that's that has DKA. In fact, there was one time I was working in the ER, and I don't know why I didn't catch this the first time, but we had a gentleman, his wife brought him in. She kept saying his pee smells weird and he just is peeing all the time. And we brought him back, we checked him out, and we actually sent him home thinking that he had a UTI. And then the next day he came back and she said, he's just not acting right. And he was still somewhat with it and talking to us, but his lips were so dry and his tongue was so dry, and he was just dizzy and very restless. Ended up that he was ended up being a newly diagnosed diabetic. So that man was in diabetic ketoacidosis. The first day he came in, but the second day he got even worse. So thankfully the wife brought him in and decided that a UTI probably wasn't fitting the bill on this one. Okay. This is also an NCLEX question, but it also crosses into a CCRN, the critical care certification as well. When a client is first admitted with HHNS or HHNK or HHS, hyperglycemic, hyperosmolar, nonketotic syndrome, the nurse's priority is to provide oxygen, carbohydrates, fluid replacement, or dietary instruction. So the nurse has a client. It's the first time he's being admitted with a HHNK. What is the first thing the nurse wants to do? Oxygen? Well, it doesn't really tell us if this patient needs oxygen or not. What do we know about HHNK? What do we know about hyperosmolar or hyperglycemic hyperosmolar syndrome? Well, this patient has a very, very high blood sugar because their body is producing just enough insulin to feed the cells a little bit so they don't go into ketosis, but they are peeing a lot. Remember Laura Aspargas's resident from the nursing home, peeing a lot, peeing so much that she can't hold her urine in. So they're very dehydrated. This patient may be a little out of it. So knowing that, and we look at these answer choices, would oxygen be a priority? It would be a priority if this patient had low oxygen, but the question isn't saying that the patient has low oxygen. So I would take that off the table right away. Does this patient need carbohydrates? Well, if a patient is coming in with this condition, their blood sugar is also already super high. Probably don't want to feed that at all. So carbohydrates is out. Fluid replacement. Would you do fluid replacement on this patient? Well, again, if you think about what this patient looks like, they're going to be very, very dry. Their sugar has been high for a long time. They're peeing a lot to try and get rid of that extra sugar. So they're probably very volume depleted. They need fluids. So C is a good contender. Let's read on so we don't get tripped up. Dietary instruction. If a patient is first being admitted with this, instruction is probably not going to be the priority, especially if you think about the patient may not be alert enough, may not be able to even take instruction. So if you picked C, that is the correct answer. You want to immediately replace the fluids in this patient. Okay, this is now, we're going into critical care questions. Which laboratory values would differentiate diabetic ketoacidosis, or DKA, from a hyperosmolar hyperglycemic state, or HHS? Serum glucose of 600, serum potassium of 4, positive serum ketones, serum osmolality of 320. Okay, let's say you read this question, you're like, oh my gosh, I don't know the values of these things. I honestly don't. You do know that glucose shouldn't be 600. You may not know the values of potassium a whole lot, but 4 seems kind of high. You definitely shouldn't be having ketones in your serum. And your serum osmolality should not be 320. 320 is pretty high. That's pretty thick. So, read the question again. Which laboratory values would differentiate diabetic ketoacidosis from HHS? Remember that The HHS is not going to have ketones because you're still utilizing some of the glucose. Or if you do have ketones, it's very, very little, very trace amounts. But a diabetic in ketoacidosis, in a ketoacidotic state, is going to have those ketones. It's in the name. So, serum glucose of 600. You could see that with both, but HHS usually is a lot higher. Serum potassium of 4. Well, you're going to have a high potassium in both. Either have normal potassium or high potassium in both. So, can't be B. C, would you have ketones in both of those? No. You only see it in diabetic ketoacidosis. And serum osmolality of 320, it's either normal or high. And if it's normal, you're not going to see it in either one. So it wouldn't be a differentiation between the two. And if it's high, you'll also see that in both of them. So that's not really a differentiation. The only differentiation in these lab values, if you look, is C. So if you picked C, you're good to go. You can get your certification. Last question, and then they let you go. I mean, I guess you can go whenever you want, but I'd like it if you stuck with me. Last question. 25-year-old woman is admitted with DKA. The following laboratories, this is a long one, the following laboratory values were reported from blood taken upon admission. Serum glucose of 450, potassium 4.5, pH 7.15. She has received regular insulin boluses and an infusion has been initiated. 2 liters of normal saline has been given. The last serum glucose is 215, so you retook everything. The last serum glucose is 215, and the pH is 7.32. Which therapy would be inappropriate? So which therapy would you not want to do? Changing the intravenous solution to include dextrose, adding potassium to the intravenous solution, administering sodium bicarbonate, slowing the insulin infusion. Okay, let's briefly read over this again. So you got this lady, she has DKA. This is what her lab values were at the beginning. The serum glucose of 450, potassium 4.5, and pH is 7.15. She already got her insulin boluses. She's got an infusion going. You already bolused some fluid, so you're replenishing the fluids that she lost. After all of that, you retake everything, and your glucose is 215. Your pH is 7.32. So we're trying to base our therapy off of those new values. Okay. So 215 and 7.32. Changing the IV solution to include dextrose. Remember what I said before, that we have normal saline, then we move to half normal saline, and then we usually move to a dextrose, a D5 with something else in it. And what is the number that we start D5 at with whatever else in it? If you remember from earlier, it's 250. So this patient is at 215. So that might be a thing to do. Let's look at adding potassium to the IV solution. So you may want to do this if their potassium value has dropped. If you know it, we haven't really talked about it in this study session, but insulin and potassium, when insulin is given to a patient, a lot of times the potassium will get driven back into the cell. They run away and go back into the cell. It also, as the patient becomes less acidotic, it gets driven back into the cell. So the potassium probably has lowered, but if you look up here, this patient was 4.5 when they came in, so his potassium is high. So we may not need to add it just yet. We don't have that lab value even available to us. Administering sodium bicarbonate. So what is sodium bicarbonate? It's a base, right? If you think about it, when you have an acid like heartburn, a lot of times you'll take a Tums or something that's basic. You're not going to take something acidic to make it worse. You're going to take something that's basic. And calcium carbonate is what Tums are, but sodium bicarbonate is also a base. I don't recommend drinking that though, because it'll really make you go to the bathroom. But that's a base. Sodium bicarbonate is a base. So our pH is 7.32. Is that normal? It's closer to normal than 7.15. So if we give this patient sodium bicarbonate, we may swing this patient's pH all the way over to an alkalotic state, and we don't want to do that. So we may need to give him, or we probably are not going to give him the sodium bicarbonate. And then slowing the infusion. Well, we dropped from 450 to 215. So that's a pretty good jump, right? So what is the question asking us? Which therapy would you not do? Would we change the IV solution? 215 is under 250. I would say this is appropriate. Would we add potassium? Well, we don't have a new value, but like I said, insulin drives potassium into the cell, so this might be acceptable. We don't have a potassium value, but we could anticipate adding potassium. Would we give sodium bicarbonate? Most likely not. This patient is pretty close to normal, so I wouldn't anticipate that the doctor's going to say, yeah, give him more basic. We're already correcting the acidosis. And then slowing the insulin infusion down. Yes, we definitely would do this because we took a big drop from 450 to 215. So yes, yes, no, yes. What's not the same? The no, C. So we would not administer sodium bicarbonate for this patient. That's all I have. So I hope you liked this study session. It was a lot of information, but it's a lot of neat information, especially because I didn't really go over the insulins. I feel like you get the insulins beat into your brain from the minute you start your nursing school. And it's pretty easy to look up those medications as well. And I've never, unless you're a diabetic educator, maybe you can memorize the peaks and the duration of the insulins, but for the most part, you're going to be able to look that up. Know basically which one's longer and which one's shorter acting. The purpose of this study session was to kind of help you think through normal process, throw wrenches in it to figure out what goes wrong and what it's called, and then figure out how to fix it. So I hope you enjoyed it, and if you have anything you want to learn or talk about or study, then go ahead, send me a message, reach out. Next time I'm going to try and figure out why PowerPoint didn't do what I wanted it to do. So for next time, stay tuned for that, and I hope you have a good week. Bye-bye.